So, I'm glad that you all were able to come here today to listen to this actually pretty fascinating topic. I think a lot of women, especially in this area, know about Pap smears. They've gone through it. There are some misconceptions, and that's kind of the point of the talk today, is talk about Pap smears and where we're going with that. First off, just standard disclosures. I have no financial disclosures that would be a potential conflict of interest with this presentation. And the goal of this talk basically comes out about because of how much there is of a lack of awareness, the lack of knowledge about cervical cancer and its screening. And you'd be surprised, but about 1 in 5 women in the U.S. do not know Pap smears screen for cervical cancer. This was a survey done in 2011. And not only that, you might be appalled to hear that it does unfortunately affect disproportionately women who are of lower socioeconomic status, as well as minority women and women who may not be essentially in a developed nation. And so in the US, we're somewhat fortunate to have this ability to get your Pap smears regularly and have them done by a professional. College-age women were not excluded, in the sense that 2/3 of women 18 to 24 thought Pap smears were the same as pelvic exams, which often is still a misconception today. And we'll get into that later in this talk, what the difference might be. 4 out of 10 women in the US were not aware of human papillomavirus, HPV as we call it, and its role in cervical cancer. And this is a major breakthrough that's happened about 30 years ago, but it's still one of the things that continues to be a topic of education. That being said, and a reflection of that statistic, in 2015, as of the latest survey, only about 42% of girls in their adolescent age completed 3 doses of the HPV vaccine. And that's, again, something that we'll get to later in this talk. So ultimately, the talk will center around HPV, and that, because of its central role in development of cervical cancer, will be something that we'll go into. And some of the common HPV-related questions or misconceptions can be summarized in this kind of true and false quiz. It's more of a pre-quiz at this point. I do encourage you to go through this with me, but by the end of this lecture, you should be able to answer some, if not all, of these questions. So if a woman tests positive for HPV, she will definitely get cervical cancer. True or false? An HPV test can be done at the same time as a Pap smear test. An HPV test can tell you how long you have had HPV as an infection. HPV testing is used to indicate if the HPV vaccine is needed. If an HPV test shows that a woman does not have HPV, she no longer needs further testing. Finally, if a woman receives the HPV vaccine, she no longer needs Pap smears. So I want you to think about that. You may not know some of the answers, or you may know all of them, but the goal of this talk is that everyone here will hopefully be able to answer all those questions. Now, what is a Pap smear? So in order to go to the future, we have to start from the beginning. And to start from the beginning, we can start with a basic anatomy lesson. Where and what is the cervix? So here you can see that let's see if my pointer is coming here. So the cervix is right here. It's the entrance into the uterus, and this is where babies happen. But it's a Latin term, comes from the word neck. And so it is at the very top of the vagina, and it is a very small organ, about 1 inch by 2 inches. And the view from a healthcare practitioner's view here is that it's about a kind of bulbous circular structure with a canal that enters into the uterine cavity. Unfortunately, this is where cervical cancer goes. Now, why talk about cervical cancer and why screen? Well, worldwide, it's still the 2nd most common gynecologic cancer, with nearly 500,000 new cancer cases diagnosed as of the last survey in 2012. About 250,000 deaths are related to this type of cancer. And in the US, because again of the developed nation status and the availability of good screening and treatment, it is only the 3rd most common gynecologic cancer after breast and endometrial cancer. But this has not always been the case. It used to be in the turn of the century, in the 1900s, the most common cancer, more so than lung and colorectal and all the other things that affect women nowadays. And if we go back in time, there was a Greek-born American pathologist, you may have heard his name, Dr. George Papanicolaou, who was studying vaginal secretions from pigs to see if he can make a diagnosis of cancer. And he essentially did enough work by 1928, announced the ability to detect in humans cancer cells from vaginal pap smears. And so over the next nearly 20 years, he developed this test. And by 1943, he and several colleagues published what's called this paper called The Diagnosis of Uterine Cancer by Vaginal Pap Smear. And essentially, since then, he had revolutionized this type of cancer, making it what was the most common cancer to now the 10th most common cancer because of cervical cancer screening. And it is still the most widely and successful screening test that we have. Now, if we go back, if you look at this kind of basic set of instruments, the pap smear itself, and this is just to review, is essentially a swab, and if you can see my pointer here, a swab of the cervix right at the what we call the transformation zone. And this swab essentially gets smeared onto a slide, and a pathologist then reads it to look at cells that may contain precancerous or cancerous changes. Just kind of as a side note, you may often wonder why you're asked to scoot all the way to the edge of the bed when you come in to see a gynecologist. And the main reason is because the speculum, which was also invented around the same time, essentially has not changed in form. It is a L-shaped device where the handle will hit the edge of the bed before we see the cervix. And so often that's why we have you scoot all the way down. Now, not much has really changed since Dr. Papanicolaou created the pap smear, and the reason it became so successful is because of several advantages. One, the sensitivity, meaning the ability to detect cancer when it's there, was about 70%, so it detects 7 in 10 cases of precancer or cancer cells. It's a minimally invasive procedure that's easy to perform, relatively low cost, and widely available, at least in developed nations. And because of how it's done, it produces consistent results across labs and between style pathologists. And the guidelines for screening and management are standardized. However, there are some drawbacks to pap smears. And as you can see, even a 70% sensitivity when multiplied across the number of women we have in the country, it misses 3 in 10 cases. And although it's minimally invasive, it is uncomfortable. Although it's relatively low cost, it does have an impact on patients in terms of opportunity cost, especially if they have to miss work, and especially if they have abnormal pap smears that require further evaluation and management. And although it's widely available in the US, it is not necessarily available everywhere in the world. And because of that, similarly, they do not have consistent results elsewhere. Standardized screening and management guidelines, although have been put out for 50, 60 years since Dr. Papanicolaou invented the pap smear, it is not necessarily adhered to by all healthcare practitioners. And you can see, and we'll talk about why. So just to recap, cervical cancer screening is a universal screening, meaning all women, regardless of symptoms, are screened, and this was adopted in the 1940s. And within 10 years of adoption, cervical cancer diagnosis rates dropped by half, which is amazing. And so if you look in 1933, you had approximately 30 cervical cancer cases per 100,000 women. And this is one way to talk about statistics. So per 100,000 women is an epidemiologic way of discussing this. By 1975, this was about 15 cases per 100,000 women, and by 2014, as of the last census, about 7.4 cases per 100,000 women. So this, as you can see, is a general trend, and deaths, although still declining, have plateaued at this point. But this is an avoidable disease. And so, we'll go into now the next part of this talk as to how to do that. And in order to know that, we should know about what drives this change in development of cervical cancer. Well, a German physician, he was also a virologist, Dr. Harald Zurhausen, in 1976, hypothesized that human papillomavirus involved itself in or had a very strong role in cervical cancer. And by 1981, he was able to link HPV to cervical cancer. By 1995, there were many genotypes found, but number 16 and number 18 were found to be in about 70% of all cervical cancers. In 2008, Dr. Zurhausen won the Nobel Prize in Medicine for his discovery of HPV's role in cervical cancer. That being said, Dr. Papanicolaou actually only got nominated. He never won the prize. And I would say both contributions were equally significant. So this is kind of the beginning of what we have discovered now. There are a handful of cancers caused by viruses, HPV being the most common, but in hepatocellular cancer, liver disease, and liver cancer, hepatitis B and C can cause chronic change. You can also see this in B and T cell lymphomas, Hodgkin's disease, leiomyosarcomas, and nose and throat cancers. Some of these other rare cancers, again, are due to viral infections, but the underlying mechanism for all these is a chronic exposure to an inflammatory process. And this is what happens at the cellular level. So this is a computer-generated model of what the virus looks like. And it causes cells to essentially, it takes over their DNA and their cellular machinery and causes them to grow uncontrollably, just like any cancer. And this causes what we term as squamous cell and adenocarcinoma, otherwise known as cancer of the cervix. And now we have basically implicated all cervical cancers to HPV. And so it is a very fascinating topic because, as we understand, most cancers are usually due to genetics or exposures, and over time your body breaks down and is unable to repair itself. In this case, it's a virus that causes it. And not only that, there are 150 genotypes or different strains. 40 of them cause anogenital infections, including warts, and just 10 of them are associated with about 85% of all cervical cancers. Now, if we drill down, specifically HPV 16 and 18, again, comprise 70% of all cervical cancers, and number 6 and 11 represent 90% of all genital warts. There are other high-risk subtypes that we've identified that make about 15% of the other cervical cancer cases. So very interesting how, with these viruses, just like anything that you would get, and currently Zika being the hot topic of our day, we're trying to race to a vaccine. And in a sense, this has been already done for us. So when we talk about HPV, we talk about how it's transmitted via a mucous membrane contact, oral, genital, anal. It's not necessarily sexually transmitted, however, the majority are. And the one thing that a lot of patients who are surprised to hear is that they find out that the transformation occurs over years, 10 to 30 years, at least 10 years to go to cancer, which is similar to disease processes that lead to colorectal cancer. Even if you had the highest of precancerous stages, what we call cervical intraepithelial neoplasia, CIN3, only 50% become cancerous. And 85% of sexually active women and 91% of men will have been exposed in their lifetime, if not more, making it the most common STD that we don't really talk about. Okay, so if you look at a recent 2013 prevalence study, this was a study that looked at women between 18 and 59 years old, and what they found is in that year alone, about 40% had genital HPV, including HPV that causes warts, and 20% had the high-risk genital HPV, those that put them at risk for cancer. And so it's actually a fairly high number, 1 in 5. 90% of these newly acquired infections, however, will clear or become undetectable within 2 years. And since 2003, we've had a pretty good molecular test. Pretty good meaning 95% of the time we can detect the disease when it's there, and when we detect it, 90 to 94% of the time the test is correct. So, some of the limitations is that this test only tells you if you've had HPV at that instance where it was tested, when the Pap smear was collected. It does not indicate the length of time HPV has been present, and that's a common misconception that a lot of patients, when they find out they have HPV for the first time, wonder how they got it and who gave it to them. Unfortunately, we can only tell you at that point in time whether or not HPV was present. So, what are some of the risk factors? Now, just like real estate, location, 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 in this case, HPV. The HPV is the strongest cause, as we discussed, the sole reason cervical cancer develops. Now, other risk factors are related to contraction of HPV, including number of lifetime sexual partners. Some of these other associations seem to be associations, but not really causation. So giving birth 3 or more times has been associated. Birth control pill usage after 5 years of usage. However, after 10 years, it doesn't seem to make a difference. Now, with this history of other STDs, such as chlamydia, all these 3 are related to having more sex. And so essentially, it's not necessarily that these risk factors cause cervical cancer, but they are tied to the risk of contracting HPV. Now, an interesting thing about tobacco usage, whether it's smoked or chewed, the carcinogens in tobacco seem to cause a immunosuppression, meaning causes the cervical cells and oropharyngeal and other mucous membranes to have an inability to fight off HPV. So it reduces the ability for your body to detect and eliminate the virus. And this is seen in patients with AIDS from HIV or patients who are chronically immunosuppressed. And again, lack of condom usage, although it's easy to think about and make sense, what we've seen with people who do use condom usage, although it does seem to reduce the risk, is not exactly known how effective that is, and since it is contacted or contracted through skin contact. Now, let's talk about the cervical cancer screening guidelines in the US. As of the 1950s, the guidelines were to do Pap smears every year. And this is probably what probably about 50% of women still think is the guideline. In 1996, the U.S. Preventive Services Task Force recommended screening every 3 years, and the body that governs obstetrics and gynecology, the American College of Obstetrics and Gynecology in 2009, finally relented and decided that there is not enough evidence to do Pap smears every year. In fact, they started recommending interval surveillance of every 2 years. And at that point, if 3 normal Pap smears had occurred and you were at least 30 years old, then you could screen every 3 years. Of course, as long as you were low risk, meaning did not have HPV or any other abnormalities. Finally, in 2012, the American College of Obstetrics and Gynecology recommended Pap smear screening to be increased in interval surveillance to every 3 to 5 years. And we'll get into that, see why that is. This is all driven by the American Society of Colposcopy and Cervical Pathology, otherwise known as the ASCTP, and they put out these guidelines which then many of the major organizations review and adopt. And so based on these guidelines, the screening intervals should start no earlier than age 21. And before, it used to be at the onset within 3 years of sexual activity. So this is a big change. They also recommend ending screening at age 65 for low-risk women, meaning no abnormal Pap smears in the last 20 years. Where it gets tricky is between 21 and 65. So when you look at ages 21 to 29, we recommend Pap smears every 3 years, whereas from 30 years old and older, it could be every 3 years as you're doing Pap smears. But if you add on HPV co-testing with the Pap smear, you find that if both are negative, you're at very low risk, again, because HPV is the cause of cervical cancer, to develop cervical cancer within 5 years. And again, it takes about 10 years on the minimum to probably develop it from an abnormal or from the HPV infection to cervical cancer. And so those recommendations are now every 5 years. If you have an abnormal Pap smear, it does prompt further investigation. This is what we call colposcopy, which essentially the evaluation, and I don't know if you can see, this is the cervix, evaluation of the cervix with a glorified magnifying glass or a microscope. The cervix is actually marinated with vinegar, same as the stuff that you buy, except it's the medical grade version. And essentially the vinegar causes transformation of abnormal cells to a whitish appearance that can be seen visually with a microscope. This is where we direct little biopsies about 2 to 3 millimeters in size, to then send off to a pathologist to confirm whether or not the abnormality is actually high grade or low grade or negative. And if negative or low grade, current surveillance Pap smear intervals with HPV co-testing is recommended every year for 1 to 3 years, depending on the abnormality. So I don't want to talk about the treatment necessarily, because we're here to talk about Pap smear and their role in cervical cancer screening. But essentially, this is, as you understand, something that many of us have dealt with over the last 50 years. However, if you think about the awareness in cervical cancer screening guidelines and what their purpose is, there is still a lack of knowledge out there. As of 2008, a CDC, the Centers of Disease Control, healthy styles survey of nearly 3,000 women showed an 80%, or basically 4 in 5 of the surveyed women knew Pap smears were to screen for cervical cancer. However, that meant 1 in 5 did not. 41% believed it was used for non-HPV STD screening alone, not just for cervical cancer. And although cervical cancer screening with the Pap smear can also detect gonorrhea and chlamydia, it is not the primary way, as there are many ways to detect that. And finally, 40.6% believed it was used for ovarian cancer. Unfortunately, we do not have a good screening test for ovarian cancer, and the Pap smear does not in any way tell you anything about that status, unfortunately. In 2012, the CDC did another survey through Healthy Styles of about 1,700 women, and at this point, as you remember, the new guidelines, the updated guidelines that moved from every 2 to 3 years, moved to now every 3 to 5 years, still about 50% of women had Pap smears annually. And these are normal, healthy women. About 35% indicated that extended interval screening would be acceptable, which is fine, except that means about 2/3 of women did not agree that they should. And I think a lot of it is due to a lack of knowledge or awareness that HPV, being the sole cause of cervical cancer, is very hard to contract when you're in a monogamous relationship. And as you continue getting older, it's unlikely that it'll show up. It's not that we don't screen any further after a certain time. We do screen just longer intervals, and by 65, more than likely, if you haven't shown it in the last 20 years, you're not going to have it. About 6.3% at that time of the survey were undergoing extended interval screening, so very dismal rates at that point. Now, 2015, a Health Partner survey of a health system in Minnesota did not show that from a practitioner standpoint anything was much better. 12% were not aware of the 2012 guidelines. 65% were aware of the guidelines for women over 30. 75% were aware of guidelines for women over 65. However, nearly half were aware of the extended 5-year interval for women 30 years old to 64 years old. And so this should, be what you assume is 100% across the board, especially if you trust your healthcare practitioner to do this. Now, again, we talked about this. The universal screening was adopted in the 1940s, and soon after, you had a fantastic drop in the number of cases. But this was a little bit mostly due to the Pap smear, but what I left out was that the HPV vaccine became available in 2006. And therefore, we now have plateaued at 7.4 cases per 100,000 women, and I'll talk about why it has not gone further. The human papillomavirus vaccine, HPV, was introduced in 2006 as a quadrivalent vaccine, meaning it covered 4 of the HPV subtypes, 2 of which cover the most common cause of cervical cancer, 70% of cervical cancer cases, and 2 of which cause the most common types of warts, 90% of genital warts. So this vaccine was given very, very good effectiveness, and yet despite that, and the administration of 3 doses over 6 months for women or girls 11 to 26 years old, the uptake or usage rate is unfortunately pretty dismal. So going to the indications for the vaccine, it was recommended, and still is, to start before the onset of sexual activity, before the risk of contracting HPV. It's still effective even after the age of 26. However, insurance companies use this age cutoff to determine eligibility for coverage. And although you won't be able to get it for free after the age of 26, you can pay for it out of pocket, but it is up to you whether it's cost effective. And that comes out to about $500 per injection for a total of 3 injections and $1,500 total. So in 2009, we introduced the human papillomavirus vaccine that had additional 5 strains, bringing it to a 9-valent vaccine. These 5 strains are responsible for an additional 15% of cervical cancer, which then brings the total protection to approximately 85%. And this, again, vaccine is about 95% efficacious, which is fantastic. The only problem is that the uptake and the usage rate is not very good. So in 1 year after the introduction of the vaccine, only 12% of American girls from ages 13 to 17 had been given at least 1 dose. And in 2008, similarly, nothing had changed, about 12%. Only by 4 years after, in 2012, did you have a 34% usage of at least 1 dose. When you look at who actually completed all 3 in the series to make it 95% effective, it was an average of 14%. So very, very dismal. So the patterns of usage and vaccination is also something that trends with, unfortunately, socioeconomic status, minority populations. Studies have shown that Hispanic women, unfortunately, have significantly lower vaccination rates compared to non-Hispanic whites. When you look at the most recent national and state level surveys, as of 2015, 62% of girls were given at least 1 dose, and about 50% of boys were given 1 dose from this age group, 13 to 17. In California, we did a little bit better, about 67% for girls and 58.5% of boys. But when we look at who actually completed all 3 in the series, essentially you have only about 42% of girls and 28% of boys. And in 2015 in California, the rates were not much better. So as a preventable disease, the vaccine should be a lot more commonly given. And when we look at the breakdown, California seems to be on the higher end of usage, where states in the South and the Midwest seem to not fare so much better. Okay, so we're back to the HPV questions we started at the beginning of the talk. And I want to go through each of these with you just to make sure every one of us is on the same page. So if a woman tests positive for HPV, she will definitely get cervical cancer. True or false?
False.
False, right. So an HPV test can be done at the same time as a Pap smear test. True. And this is what we call co-testing, which is why we're able to offer 5-year interval surveillance instead of every 3 years, and instead of what was commonly thought of now every year. An HPV test can tell you how long you've had an HPV infection.
False.
False, right? And this is because the HPV test, although it's a very good test, it only tells you whether you have HPV at that time that you were tested. And although it can pick up about 95% of cases, it misses about 5 in 100. And so we don't stop testing, we do continue testing, but we can't tell you how long you've had the HPV infection. Now, HPV testing is used to indicate if the HPV vaccine is needed. It's false, right? Essentially, this is not a test to see if you have been immunized and you have titers. This is a test to see whether or not the cervix harbors HPV. And unfortunately, HPV as a vaccine is only about 85% effect, or 95% effective, but 85% coverage. There's about 15% of HPV strains that cause cervical cancer that is not covered by the vaccine. And so HPV testing continues despite having had the vaccine. It just is a insurance, so to speak, just like any vaccine that helps reduce your risk for contracting HPV-related cervical cancer. If an HPV test shows that a woman does not have HPV, she no longer needs further testing. False, right? And we just talked about that. Essentially, with HPV testing, although it can be negative, doesn't mean that, one, we picked it up. We did probably pick it up 95 out of 100 times. But it doesn't mean that if you aren't in a monogamous relationship, maybe you might have a new relationship and that partner of yours has HPV and you don't know it. There is no test for men, essentially, that is like the one we have for women, a universal screen. And so often we're left with whether or not the partners that you might come across have HPV, And if they do, you will pick it up. So testing is indicated to continue. If a woman receives the HPV vaccine, she no longer needs Pap smears. False, right? This is the major takeaway point, is that although the vaccine is great, it does not have 100% coverage. And so when we talk about the annual exam, and this is something that we touched upon in the beginning of the talk, a one-woman exam is still recommended every year. However, we have to unlink ourselves from the annual exam and the Pap smear. The Pap smear is just one component of the annual exam, but is no longer annual. Again, from the ages of 21 to 29, we recommend this every 3 years for low-risk women, especially if you haven't had abnormalities. And the same goes in the ages from 30 to 65. If you just have Pap smear screening alone, it's every 3 years, but every 5 years if you add on that HPV co-test. Of course, the annual exam also includes SE testing, especially if under the age of 25. And when age appropriate, breast cancer, colorectal cancer, anemia, cholesterol, thyroid, and diabetes screening. So again, this is something that should be done on an annual basis for talking about what needs to be looked at and maybe other questions you might have about your health. The exam itself should just be a exam plus or minus the Pap smear, depending on if you're low risk or high risk. So going back to the title of this talk, the future of Pap smears, a couple things that need to change. We need to improve the awareness of Pap smear screening guidelines as of the 2012 guidelines that have been put out. We should try to improve the knowledge of HPV, which may increase and hopefully will increase the HPV vaccination rate. And there are novel approaches to screening on the way, as we talked about since the 1940s. Not much has changed in terms of how we screen for cervical cancer with the Pap smear. But we do have something on the horizon called primary HPV screening. In South Florida, there was something called the Sussex trial in 2014. They evaluated whether it was acceptable for women, especially in women who are high risk, minority women, ages 30 to 65, and in Florida this included Haitian women, Cuban women, Hispanic women who had not had a Pap smear for the last 3 years. And what they asked them was whether or not they would be willing to swab themselves to look for HPV from the vagina. And now, as of this year, this trial is going forward where they are mailing HPV self-sampling kits to women. And if you have a self-sample that becomes positive for HPV, that puts you then in a category for you to come in to do a Pap smear, to then actually look at the cells to see if they are abnormal. So the way it looks at HPV as a cause for cervical cancer is the correct way. HPV, the virus, causes cervical cancer. If you don't have the virus, it's unlikely that you'll develop the cancer. However, what isn't said here is that women who are under 30, especially when they're sexually active, they tend to have HPV. And again, like I said, about 90% of men and women have HPV at some time in their life. And we know that it clears within 2 years for the majority of women. And so we actually don't want to know for women under 30 whether or not they have HPV, because we have found that by doing too much screening, it leads to false positives, to true positives that actually don't meaningfully change the outcome, meaning that the women under 30 are young and they're healthy, and they, although contract HPV, they clear it. And without looking for it, we tend to do less procedures that are not really indicated and don't change the overall outcome. Healthy People 2020 is an organization that aims to reduce, eliminate, or maintain elimination of cases of vaccine-preventable diseases. And they've targeted cervical cancer, especially HPV vaccination rates, with a goal of getting it to about 80%. And remember, we talked about where it is now. The completion of all 3 doses, it's dismal. It's about 50%. And this is something that should be offered to all girls and boys ages 13 and 15, and hopefully can be achieved by the year 2020. So let's talk about some of the case studies here. In an era of HPV vaccine, again, it's been out since 2006, nearly 11 years. When it first came out in Australia between the years of 2007 and 2009, they instituted a HPV vaccine program where 70% of women were vaccinated between the ages of 12 and 26. And during the 3 years, at the start of the initiation of the program, they found a 38% decrease in the prevalence of high-grade precancerous lesions, which is, the most evidence you can have that shows HPV vaccination works. And when you look at the U.S., this was done in Connecticut as a study where a statewide registry recorded women ages 21-29 from the years 2008-2011. During this time, vaccine usage increased from 45% to 61%. And what they found was, in this age group of 21-24, there was a decline of prevalence rate of high-grade abnormalities, just similar to what was seen in Australia. But this was reported as per 1,000 women. So in 2008, 834 cases per 1,000 women to then 688 per 1,000 in 2011. So again, we know the vaccine works. However, we also know that the usage rate is unfortunately still low. Another group put out an estimate in 2014 that if we were able to achieve a 70% vaccination rate, there would be approximately a decrease of 345 cases of cervical cancer per year and a decrease of 178,000 cervical cancer cases per year in the world. Okay, so just to conclude, let's review some of the fast facts here. So HPV is the most common STD. We just don't talk about it like we do other STDs. Cervical cancer and precancer is caused by HPV. We know that this is true based on all the studies we've accumulated over the last 30 years. HPV-related cervical precancer and cancer changes are slow. They take about 10 to 30 years, on average about 10 to 15 years. HPV-related anogenital infections, including warts and cancer, can be easily prevented 85% of the time with a vaccine. And that's not something you can say about most cancers caused by a virus, or most cancers in general. And we have a vaccine. Pap smears no longer need to be obtained annually if low risk. And HPV testing should not be performed under the age of 30. Okay, so I'll now leave this open for any questions that you may have. I do have references for all of these statistics if you need to at the end of this talk. Any questions? Yes?
Actually, I just kind of have one on the abnormality. If you are, did I understand you to say that it clears up within 2 years? And then what happens?
Well, the caveat to that is that when you are young, on the average time frame, it is about 1 to 2 years. However, as you get older, or if you have medications that cause some sort of immunosuppression, such as rheumatoid arthritis, and medications suppress the inflammation, you will find that the HPV, human papillomavirus, does not clear as easily. And we see this in smokers because of that relative immunocompromisation at the level of the cervix. In smokers, these young women even do not tend to clear it very quickly or at all.
Define young for me.
So usually under the age of 30, where you find we don't actually look for HPV because we assume it clears pretty quickly. And when you look at HPV number 16, which is the most common strain, and it comprises about 40% of the 70% of in that group 16 and 18, the HPV 16 is one of the most aggressive subtypes and the most common. And this can take on the order of 2 to 3 years in women under 30, or longer, 3 to 5 years for women over 30. And so it depends on where you are in your life and how often you've had HPV, and if you've cleared it and it's been a long time, years, it's more than likely if you develop HPV again and you've been with a new partner that you contracted something new. If it's that you've been with the same partner for 15, 20, 30 years, it's possible that the test for HPV had missed the virus when it was done. And that's why we still recommend, if you've had abnormalities in the last 20 years, by the age of 65, we still continue surveillance.
So what would it be recommended after age 65 annual PAPs, or what would be?
It depends on what your abnormality was. So if you had an abnormality in the last 20 years, we still continued the interval surveillance of 3 to 5 years if you did Pap smears alone without HPV testing, 3 years, but with HPV testing every 5 years. And we find that probably by the time that you're 70, 80, 90, I mean, something else is going to get you because of how long it takes for HPV, right? You're going to get hit by a bus, you're going to get hit, by lightning, you might die from, just being on vacation somewhere. I mean, this is something that ends up being more likely. And we have other cancers that affect women, primarily breast, lung, colorectal, thyroid, melanoma, that unfortunately are much more prevalent. And so when you look at HPV screening guidelines, this is a national guideline that factors in the, again, costs of the test to the system, to the patients, the convenience, whether or not it's cheap and easy to access. But when you get to that age, it tends to be less of an issue to develop cervical cancer versus something else. So colonoscopies are important, starting at the age of 50, and breast cancer screening with mammography continues to be the case till age 75.
Thank you.
All right. Yes.
My apologies for bringing in boys, but I noticed you brought them
Yes.
in there. Is there still merit to up to the age 25 for young men to?
Right, and it's not just because it's covered, but if you look at HPV, it is a sexually transmitted infection, which means it takes two to tango, right? You have one, unfortunate gender that is primarily affected, and because of the politics of creating a test, because men aren't really affected, and we didn't talk about what happens to men. I mean, there is a small risk, but it's significant, especially for men who have sex with men, for anal cancer, which is primarily HPV-18, oral pharyngeal cancer, which again, HPV-18 and people smoke. If you look at Michael Douglas and Catherine Zeta-Jones, and the reason he blamed her for developing his cancer is because of oral sex. And so if you find that you just vaccinate half the population, the one that's affected, sure, you may help them, but really it should be more of a cocooning strategy where if you vaccinate both sides, both partners, you tend to then eliminate the virus that then causes a disproportionate amount of cancers in women.
So, I have a 23-year-old male.
Yeah.
And so he should maybe still.
Yes.
I did not know that. I thought, you get it in that early teens.
Sure.
And that's it. No.
We try to do it because, again, you want to initiate hopefully before the onset of sexual activity. Because what happens is if you already have had sex, and more than likely you have been exposed to one of the 150 genotypes of HPV, you will likely clear it when you're young. And you will develop your own antibodies to that genotype. But there's so many different genotypes, maybe you haven't been exposed to one that we do have a vaccine for, in which case could be preventable in the future. Right. So again, it's not necessarily something that men think about. But if we're going to be in a society where we're treating something that can predominantly affect women, men need to be involved. Just like when we have children and men kind of don't participate, it's a disproportionate system where it's not sustainable. Okay. Anything else?
Why you start at 13 and 15 years old?
Why do we start at 13 and 15? Actually, it's recommended to start at 11 to 12 years old. Right, before the onset of sexual activity. Right, because the average, you might be surprised to hear, maybe you haven't heard this, but the average age of onset of sexual activity, depending on where you are in the U.S. and the rest of the world, is actually in your teens. Right, in some places a little older, and some places a little younger. And so these recommendations, as a national recommendation, have to factor that in. Okay. Anything else? Fantastic. Well, if you have any other questions or you want to talk to me or ask me questions up here, I'm more than happy to stay around and answer some questions at the very end.
Thank you so much.
Of course.
Thank you.